For decades, equine practitioners have relied on radiographs and ultrasound for imaging musculoskeletal problems, but there are many cases that still require advanced imaging for a better answer. The first one to come along was nuclear scintigraphy. Next was magnetic resonance imaging, or MRI, and then along came computed tomography, or CT. With the introduction of PET scanning, there is no doubt that advanced imaging offers many options to provide the most concise answers for hard-to-diagnose lameness and performance-related problems. I've had a hard time keeping up with the advantages of each of these imaging modalities, so to help us understand what PET scanning is and how it compares to other forms of advanced imaging are Dr. Bills from New Bolton Center and Dr. Crandall from Fairfield Equine Associates. Both of these individuals have a robust background, so listen carefully as I introduce each of them to this discussion. Dr. Kate Bills obtained her VMD from the University of Pennsylvania in 2012 after graduating from Tufts University with a degree in biochemistry. Following a rotating internship in equine medicine, surgery, and critical care at the New Bolton Center, Dr. Bills completed a diagnostic imaging residency at Tufts University Cummings School of Veterinary Medicine. She became board certified in diagnostic imaging by the American College of Veterinary Radiology in 2016 and received additional board certification in equine diagnostic imaging in 2022. Dr. Bills joined the faculty of New Bolton Center, University of Pennsylvania, in 2016 and is currently an associate professor of clinical large animal diagnostic imaging. Dr. Bills' work at New Bolton Center focuses on the clinical applications of advanced imaging systems, including CT, MRI, and novel standing imaging systems, including PET and robotic-controlled cone beam CT. Dr. Alycia Crandall. Dr. Crandall obtained her undergraduate, MBA, and DVM degrees from Texas A&M University. Following a private practitioner internship in California, she completed a rotating internship and her large animal surgical residency at the University of Pennsylvania at New Bolton Center. You see an underlying common theme here. After acquiring board certification in surgery and practicing for a season in Australia, she joined the team at Fairfield Equine Associates in 2024. She has a wide appreciation for all aspects of sports medicine and surgery, covering both elective and emergency procedures, with specific interest in advanced imaging, emerging surgical technologies, and postoperative therapeutic management. So I'm going to start off with a question. I'm going to ask each of Dr. Bills and Dr. Crandall to answer these, but I'd like Dr. Bills to start off with my first question, which is, very simply, what is PET scan and what imaging information does it provide?
Sure. Thanks so much for the very warm welcome, Dr. Baus. So, positron emission tomography, which we colloquially call PET, is a three-dimensional functional imaging modality. You can think of it as a 3D bone scan. That's probably the best analogy. And it evaluates biologic and metabolic activity rather than purely anatomical structure. So that is sort of the short version of what information it provides. And roughly the way it works is that we inject the horse with a radio tracer, and we'll talk about some of the tracers in a little bit, intravenously, very similar to bone scan. And then the substance that we inject undergoes positron emission and it interacts with the tissues in the horse. And from there, it releases two gamma photons that are measured by a detector. And the detector, which you can actually see in the shared images from Dr. Crandall here, that's the circle around the horse's leg, that captures the radiation and helps us localize where the issue is coming from in the horse. And we really value PET scan because it helps us detect physiologic change before structural abnormalities. And in a little bit, we'll talk about some other things, but it's very useful in identifying sources of lameness and inflammation.
Yeah. Anything to add to that, Dr. Crandall?
Similar to how we think of CT as the three-dimensional or tomographic form of X-rays, that's sort of how we see the same translational applications from PET scan as what we were previously used to with nuclear scintigraphy.
Okay, good. So I have been dying to ask this next question. And again, we'll have Dr. Bill start off with this. So the two qualities that are attributable to imaging are sensitivity and specificity, correct?
Yes, absolutely.
Could you describe these attributes as it pertains to PET scan, and then how it also compares to MRI and CT scans? In my mind, the conventional nuclear bone scan has good sensitivity, has very poor specificity. Is that correct?
Yeah, that's a very accurate summary.
Okay,
Um,
so I'll let you take it from here.
yeah, perfect. So PET scan also is extremely sensitive, and it's actually more sensitive than nuclear scintigraphy. So in that realm, it's quite similar. Similarly to scintigraphy as well, it is specific, but it does not have the same specificity. And basically for us, that's the ability to provide a very specific diagnosis. So you could think of that as if you were doing a CT, for instance, that modality has a greater ability to say this horse definitively has a fracture, for instance, or the horse doesn't have a fracture. With PET, what we actually see is something more along the lines of there is an area of abnormal bone activity in this particular bone that is very sensitive. It's going to be picking that up before the other modalities, but it can't tell you at what point in the disease process we're actually seeing. So it could be very early, but very active bone remodeling, or the horse could be it could be fractured. So it can be all within that spectrum. And we use the degree of uptake to help us guide the order that we think those things are happening, whether or not we think a fracture is likely or not. But unlike the other modalities, it is not as specific as we would like. So MRI tends to have quite high sensitivity and specificity. So it tells you where the problem is and what the problem is with a greater level of detail for soft tissue, especially, but also to a certain degree bone, particularly with high field MRI. And then CT is going to have a little bit of a lower sensitivity for early disease. So we see a lot of early bone change, sclerosis is one of those examples. And we don't see lesions specifically on the CT that we could attribute to lameness, whereas we may see lameness attributable lesions on the PET scan. And so in that respect, the PET will identify lesions earlier. The CT, the same process is still happening in the horse, but we can't actually see what the problem is. Now, the nice thing about CT is that it is very specific for osseous lesions. So things like fractures or incomplete fractures, subchondral bone injury, osteoarthritis, and that sort of thing. So yes, PET, like scintigraphy, is highly sensitive for early physiologic and metabolic changes, but only moderately specific. I kind of think of it as the the sensitivity is where the problem is. So we can identify that this bone has the problem, and the specificity is what the problem is. So this bone is affected, but I don't know the specific diagnosis. Whereas, something that's really specific is saying like this is a fracture or this is osteoarthritis.
Yeah,
So that's how I think of it. It's kind of a where and the what.
yeah,
Yeah, yeah. And the clinical application of that is, we might see increased radioavidity or increased uptake on the PET scan, but that's not going to tell us exactly what's going on, right? So the structural capabilities of the CT or the MRI are going to say, hey, we see this increased uptake in the bone, but we don't know, is that because there's a fracture? Is there an enthesopathy going on? Is there simply a significant degree of sclerosis or subchondral bone remodeling? So while the PET is able to tell us this is an area of increased metabolic activity, it may not tell us exactly what the structural abnormality actually is.
yeah. So when I think of a bone scan, a traditional bone scan, that's going to tell me where the problem is, but it will give me no idea what the problem is. unless of course the location is so specific to that.
Right.
Whereas with an MRI, which has very high specificity, that will tell me what is abnormal, but may not tell me where the problem is. Is that fair to say?
Yeah, I think the MRI conveniently, at least, because of the spatial resolution that we have, very often it gives you a little bit of both. So it may tell you that the deep digital flexor tendon is affected and the degree of fiber disruption that you're dealing with. And I think in comparison to the PET, what that will tell you is the deep digital flexor tendon is affected, but not the severity of the tear. All it's telling you is that there's abnormal metabolic activity in the deep digital flexor tendon, for instance. And
Okay.
sometimes then when you go to do the MRI, the horse has a giant tear or the horse has a very small tear. And those prognoses are, of course, certainly very different.
Yeah.
Um, so the PET can help us get to the right area to image as well.
Good. Dr. Crandall, when we are using the PET scan, we're starting with the radioisotopes. Do you prefer radioisotopes or radio tracers?
I think we use both interchangeably.
Okay. And which are used in the equine for musculoskeletal problems?
So there's two that we'll reach for. One is sodium fluoride. That's considered our bone tracer. So that's going to be correlated to the degree of bone turnover. And then we have our fluorodeoxyglucose, which is a bit of a mouthful. The abbreviation for that is FDG, and that's considered our soft tissue tracer. And so that's related to glucose metabolism, which can be increased in areas of increased inflammation or infection, or some of the initial crossover from human applications came from this being used for looking for neoplastic processes as well. So we will commonly use both of these together. They can be injected in the same day. They're not injected at the same time. Usually one is injected in the morning and then that scan is performed, and then the horse has about 4 to 5 hours in between, is allowed to wake up, move around a little bit, and has the second injection, which is then performed later in the afternoon.
Okay. And Dr. Bills, my surprise question for you. Uh, um, so, what would happen if you gave the isotope for a bone scan and then did a PET scan on it? What would that look like?
That's a great question. So essentially, what ends up happening, because both of the emissions end up with gamma rays, is that the PET gamma rays are very, very high energy. So they are, this is maybe getting a little too technical, but they're 511 kilo electron volts. And to compare that to a bone scan, that's 140.
Oh, wow. Okay.
Yeah,
Big
so it's
difference.
yeah, it's quite a bit higher energy, which is why we have to be reasonably careful with the radiation safety. Um, this doesn't exactly answer your question, but kind of related. The half-life of the PET isotopes is much faster. So it's 110 minutes versus 6 hours. So we can manipulate the use of the half-lives in order to time the scanning so that they don't interfere with each other.
Okay.
If one were to give the the technetium, which is the bone scan tracer,
Hmm.
if we were to give that and then we still wanted to PET scan the horse, we just wait a certain period of time so that the 140 energy is not interfering with the 511 level energy. That being said, the 511 is a much higher energy, so most of the time it's actually not a problem. It causes what we call noise. So there's
Okay.
like some background information that is being captured by the detector, but you can, we don't typically do that, but you can get around imaging in close succession, both of
Okay.
those modalities.
And a question for both of you. Are there other radio tracers coming along that might image differently?
Sure. Yeah, that's a great question. And in human medicine, they have various tracers for different purposes. So some groups are looking for pain-specific receptors. So we are capturing bone metabolic activity currently, but that doesn't necessarily correlate to lameness. Whereas you would suspect that if you had a tracer that's specific to pain, that that could maybe give you more specific information. Again, increase your specificity for the lameness causing region of the horse. So there are some novel tracers that look at pain receptors. We're also looking into a brain scanner in horses, and so dopaminergic and other sort of neurodegenerative tracers may also be available. There's also a germanium tracer that looks at vascular flow in the foot, and we may be using this to look at laminitis and distribution of blood flow in laminitis patients. So there's several different tracers, and I'm not an
Yeah.
expert on those. So,
So the uses
but
could go well beyond what
yes,
we currently know. Yeah.
yes, yeah.
Anything to add to that, Dr. Crandall?
No, I think Dr. Bills is at the forefront of
Okay.
discovering all these great new applications for this.
Okay. So, Dr. Crandall, what areas are you able to scan with a PET scan?
So we're able to scan the distal limb, as you can actually see in these two images here. Neither of these have the machine at its full proximal most positioning, but it's quite close. So we have a 67 centimeter field of view with the machine. And so in most horses, that allows us to go basically from the level of the chestnut distally in the forelimb. So that's from proximal to the accessory carpal bone, encompassing the entirety of the carpus all the way down through the foot. And then in the hind limb, I would say in most horses, and even in some impressively tall warm bloods, we're able to get from the top of the calcaneus all the way down through the foot as well. The limitations to going any higher than that, as you can see, because it is a round gantry, you have to be careful about where the horse's abdomen or chest is coming down. And in the hind limb, it would be pretty difficult simply because of the angulation of the tibia. Having to move up and down that is pretty limiting with horses. And even when we're doing full limb scans in the hind limb, the machine itself does have to move a little bit to accommodate, depending on the degree of natural extension that the horse has in the fetlock. But it's pretty neat. I can even share some videos for you, but to show, we're able to scan from the top of the calcaneus down to the hoof in a single continuous study. And with the motion correction technology that the machine has, we're able to make that look like it's one continuous scan, even though the scanner may have to move slightly to accommodate the different angles of the horse's limb as it moves down.
Okay. So you have an approximately 2 foot length that you can image. And it looks to me like you're placing something on the bottom of the feet so that you can go down all the way to the bottom of the foot. Is that correct?
Correct. It's that way you're able to get all the way through the solar surface. So it's similar to when we're doing standing CTs with the robotic CT system. Those horses are also on blocks. That way we can have the detector go to the bottom of the foot as well.
Okay.
Mhm.
All right. Anything to add to that, Dr. Bills?
I think that's a great summary. The
Yeah.
only other thing that people very often have questions about is like what happens if something goes wrong. And
Oh
so
yeah.
the nice thing about this system is that the ring that is around the horse's leg actually opens. So you don't have to put their leg sort of through the ring. You like close the ring around their leg. So the safety mechanism allows them to back up easily.
So
Um,
it's not locked shut. It's just
Exactly.
got it.
It's like
Okay,
a
good.
it's like a strong magnet so that
Yeah,
if the
good.
horse were to
Okay.
were to move, then it just comes
Okay.
apart. Yeah, it's very safe.
Yeah. Oh, here
Yeah,
we
Yeah.
go.
we have a
Mhm.
great video here. This is from Dr. Bills at New Bolton Center, showing quickly how we'll acquire a scan. So they'll walk up to the horse and open the gantry, and it's really nice too because you bring the machine to the horse. When we're
Mhm.
doing standing MRI image acquisition, half the difficulty sometimes is getting the horse to come to the machine and stand still comfortably in it. And we find it's much easier to get the horse to be compliant when you get them settled in a nice position within the room and you can bring the machine up to them.
Yeah.
Yeah.
And I'm just curious, is there motion correction software that's included with this? Okay.
hmm
So just
It's very impressive too. I mean, the horses can sway quite a
yeah.
bit, and
Yeah.
then the image at the end looks like they were perfectly still.
All right. Dr. Crandall, in the cases that I have referred for a PET scan, almost all of them had another modality used, whether it was a bone scan or an MRI. Is that fairly universal that that we will use the PET scan in conjunction with either an MRI or a CT?
I think it's very common, and the imaging modalities certainly complement each other, but it's not necessarily required. And a lot of that depends on why the horse came in. Sometimes we have lesions that we can see on radiographs or on ultrasound that are obvious enough that we can then use the PET scan to supplement that. Sometimes the lesion itself is obvious enough, and we are fairly confident with our, baseline imaging that we don't need to do anything tomographic in the form of a CT or an MRI. So we're simply able to use that. An example that we can use later on in some of our case examples are proximal P1 sagittal groove lesions. We know that those can definitely have a variety of appearances with CT or MRI, but in some horses, we're simply just trying to show, hey, this is where there's an area of subchondral bone injury, and we know that we need to make alterations in the horse's exercise and training regimen because of that. And so we're simply able to use just the PET scan and then be able to use it as a longitudinal follow-up to track how that horse is doing over time and use the PET scan in correlation with their clinical picture to see how they're
Okay.
improving.
Okay. Um, Dr. Bills,
Mhm.
could you just run down some of the common findings from a PET scan?
Sure. This is a little
And
bit,
just to interrupt real quick, uh,
yeah,
one of the things that is, and I'm sure this frustrates you as well, but when we started in this profession, we were handed a bunch of diagnoses that were very old, right? And now they've been completely changed. And so our clients still want for us to present to them a diagnosis that fits one of those old descriptions, and now nothing fits the old descriptions, right? So, and we can get into that a little bit later, but if you would just tell us what some of the common findings are and how they might relate to some of these old labels that were put on them.
sure. That is such a good question. And a little bit related to, what Alycia was just talking about in terms of the requirement for having a CT or an MRI. The other thing that we'll use sometimes the PET scanner for, which goes back to what is the specific diagnosis and how does that relate to sort of I'll use navicular disease, for instance. That's probably one of the most common that people are says, does my horse have the navicular disease or
Right,
don't they?
right,
Um, one of the things that we use the PET scanner for is also screening. So a horse that sort of blocks oddly or inconsistently, and you're trying to figure out which part you want to MRI, and you're having a hard time sort of narrowing that down because the MRI takes such a long time to run. Sometimes we'll use the PET scanner for that. And then specifically related to the podotrochlear apparatus or navicular disease, we now know that that disease process is really a compilation of both bone and soft tissue injuries, and the primary bone being the navicular bone, and then the primary soft tissue injury being to the deep digital flexor tendon, but they also have regional ligaments that can be injured. With the PET scan, we actually discovered there's sort of a new ligament that we had previously been ignoring that can be a source of lameness. And so, using the PET scanner, we can be more specific about what specifically, is happening in a horse's foot. So, if we use both the bone and soft tissue tracers, we may end up with a horse that has what we call primary navicular disease. So the bone itself is injured. It has a bruise type injury, or typically it's chronic repetitive trauma that the horse is experiencing. Or the bone may be completely normal metabolically, but the adjacent tendon, so the deep digital flexor tendon, is primarily injured. Or we can see a horse that has both tendon and bone injury. And the important thing about that is each of those horses is treated completely differently. So they can all be lumped into a horse with quote unquote navicular disease, but Dr. Crandall is going to make a different recommendation about surgical consultation. You are going to make different shoeing and therapeutic recommendations based on the specific structures that are injured. And really, the more specific we get with our diagnosis, the better we can make a more specific treatment option. And then in the long term, we're going to be able to see how effective those treatments are because we have the most accurate sort of starting point.
Yeah.
So that's kind of a long-winded answer for that one, but navicular disease is definitely one. The
Yeah.
other one is hind suspensory disease. So and forelimb to an extent, but I think that hind suspensory tends to give us a little bit more of an issue. So similar to navicular disease, it turns out suspensory disease also has bone and soft tissue components. So the attachment of the ligament to the bone can be the primarily injured area. The ligament itself can be the primarily injured area, or a horse can have a combination of bone and soft tissue injury, and those horses are going to be treated differently. The other thing that's terribly inconvenient for us is that when we're localizing horses with that pathology, very often we're using a subtarsal block, so a perineural analgesia of the hind limb, and it turns out that that actually blocks the distal tarsal joints too. So we can use the PET scanner to figure out if the bones in the hock are the problem, the bone at the ligament attachment is the problem, the soft tissue is the primary problem, and it's incredibly helpful from that perspective to sort of cross things off the list. And
Yeah.
certainly there are horses with multiple issues as well,
Yeah.
and that's important too, prognostically for us.
So all of that information becomes valuable, both in terms of how we're going to treat that condition, also how we're going to monitor its progress over time. So that level of specificity added on is a tremendous benefit.
Mhm.
Dr. Crandall, I'm sure you have some more to add to this.
Yes, actually, and I had some images too that would be helpful, I think, for this specifically. So in this here, going back to Dr. Bill's point, in terms of using this for proximal suspensory disease, again, going back to us talking about having two tracers is really beneficial, right? So these are two different horses, both of which had proximal suspensory changes. The top is a multiplanar reconstruction in a hind limb, and the bottom is multiplanar reconstruction in a forelimb. But and both are FDG. So just as a refresher, this is looking back at our soft tissue metabolic activity and showing we can actually have a significant amount of abnormal change or increased radioavidity or increased radiopharmaceutical uptake in this proximal ligament, but we can also see it in the bones. So in this slide image here, in the top, you can see the FDG, which is the soft tissue uptake, and in the bottom is the sodium fluoride, or the NAF, which is our bone tracer. And in this case, the horse had uptake both in the soft tissue and the bone, which sometimes we see, sometimes we don't. But it does give us some good information too, especially if this was performed as a screening modality. What is the next best, or what should we recommend as our next imaging modality? If the horse only has uptake on the bone tracer, we may be more inclined to suggest doing a CT, versus if we have no or minimal uptake in the bone, then we're going to recommend an MRI to look at the structural changes to the suspensory ligament itself. And we can use that information and overlay it to then say, okay, the next recommendation was a CT. Does this horse have increased uptake in the bone because it has a very large enthesopathy back there, or does it have an avulsion fracture off the suspensory ligament? And that's all really good information for us to be able to present back to the owner to help determine prognosis, and then also kind of have a better conversation about, is surgical intervention even warranted in this, or is this a horse that we should just try treating medically?
That overlay that is an incredible image there. That would be very useful for anybody to see and know instantly what's going on with that. So yeah, thank you for sharing that.
And us simple-minded surgeons also appreciate it because we like colorful things that say the problem is here and
Uh,
we should look here.
Yeah, I'm like a crow too. I like shiny things.
Yes,
yeah,
exactly.
yeah,
But truthfully, it is very helpful in terms of communicating with owners,
yeah,
right? I think explaining the concept of sclerosis and demineralization, these are big words and can seem very intimidating, but
Yeah.
having
yeah.
a picture that's very easy for people to see, truly, I think it helps the message come across more clear and helps people make more informed decisions.
I
Yeah.
totally agree.
Yeah. Excellent. So I have one final question and plus follow up with anything that you'd like to. Uh, of the cases that I have referred for a PET scan, one of the most common findings is radioisotope uptake in subchondral bone, that bone immediately underneath the
Mm.
joint cartilage. Uh, how would you classify this sort of a finding? Is it pre-arthritic? Uh, is it an acute finding? Is it tend to be chronic? How would you put that subchondral uptake into a more common vernacular so that we can better understand it?
We had a slide for this.
Wow, holy
Yeah.
cow, look at that.
So, like you said, the subchondral bone, again, breaking that down, right? So, sub beneath chondral relating to the articular cartilage. Our subchondral bone is a very important part of our, even though it's technically outside of the joint, but it is considered very important in terms of supporting the joint because that's what's immediately underneath our hyaline articular cartilage, and supporting that. But because of that, it's very responsive to the loads that are placed upon it. And horses can have a maladaptive response to the stresses placed upon that bone. And it's important for us to know when that bone is potentially having a maladaptive response or has some sort of subclinical or early pathologic change, because if nothing changes about the horse's exercise routine and that's allowed to progress, then what eventually happens is that cartilage that's overlying that subchondral bone is going to collapse. And once we've had articular cartilage collapse and permanent damage to that articular cartilage, then that's a permanent change and we're never going to be able to go back. And so, what we would like to do and what we try to accomplish with our musculoskeletal evaluations and advanced imaging is trying to identify these problems as early as possible. That way, we can make changes before they're permanent. And so when we say that we identify subchondral bone changes, we're trying to point out areas that a horse may be undergoing repetitive stress remodeling, um, and being able to then adapt and follow up with that, as the horse has an active form of rest or modification in its exercise regimen that allows that bone to undergo a more adaptive, normal stress remodeling process.
Okay.
This, I think, goes back to, you were talking about owners saying that, there are these like new diagnoses. I feel like this is one of the biggest that
Yeah.
people are like, why are we only now learning about this? And something that's important to remember about that is when we were using mostly radiographs and ultrasound, radiographs are wonderful, but they are actually quite insensitive for bone change. So
Yeah.
it takes about 30% bone loss before we're going to see that, or bone addition to see that radiographically. And it turns out that a horse can become lame well before you see that radiographic change. So um, the nice thing about the PET system and especially CT and MRI is that we see those bone changes earlier than what we would see on radiographs. We're going to see those changes earlier. And the other thing that is important that I think is a little bit misunderstood by horse owners that is helpful to clarify is that the vast majority of these injuries are from chronic repetitive trauma, which Alycia mentioned. So it's not impossible that it's a single event, but that is the least likely sort of course that happens. So you do get a horse that takes a single bad step and is acutely lame. It happens, but the vast majority have chronic wear and tear that is just subclinical until the horse it then becomes lame.
Yeah, and that's
And
a very hard thing to convince people of because their
yes,
recognition of that lameness occurred immediately.
yes,
So they
and
review
they're
everything
and
that
they're
happened.
right. Yeah.
Yeah, yeah,
And yeah, and they're right. They did identify the lameness acutely because, as Alicia was describing, the horse's body is trying to adapt their bone in order to compensate for the stresses that are put upon it. And the
uh,
horse is compensating, 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 and all of a sudden they're not compensating. And
yeah,
that's when the apparent acute lameness happens. So the lameness may be very acute onset, but the cumulative damage has happened over a longer period of time.
Yeah.
Yeah, and we see evidence of that. We see it on the PET scan, but we see that more in the MRI and the CT. So the MRI and CT provides us with more evidence that the injury is chronic, typically, whereas it can actually look quite similar on the PET scan. So it's going to be hot. If it's an acute event or it's a chronic, like repetitive trauma, it looks pretty similar
Yeah.
on the PET scan. So,
Yeah. It's hard for people to understand that this is not a new condition.
yes, just
This,
newly recognized.
yeah, it's not
Yes.
because we're so smart now. It's that we weren't so smart then.
And I think the other thing with it too that's scary, it's not, it doesn't have to be, because we're catching it early, it doesn't have to be a permanent injury, right? And that's
Yeah.
one of the benefits of this imaging modality is being able to show people when you've changed the exercise routine and you've changed what the horse is doing and you back it off and you allow what's become a maladaptive process to go back to its normal physiologic adaptations, the bone can actually heal.
Yeah.
And one of the, we were able, and with some certain sequences of MRI, be able to see how the bone metabolically was changing its activity, but sometimes there were lesions that would structurally remain permanently abnormal. And it was hard to then be able to give useful information back to an owner or to a trainer and say, hey, this is improving and we should bring the horse back into work.
Yeah.
So in this example that we have here, this is something that we see very frequently where we have a horse that has increased uptake in the proximal sagittal groove of the proximal phalanx. And over the course of the summer, they modified how this horse was working, backed off on its jumping. This isn't a horse that went back into a stall. That's usually actually contraindicated. We want them to be moving and be moving in a more normal fashion for them to be able to re-stimulate that bone to start turning over to heal appropriately. And the horse clinically was improving over the summer, and we were able to see that in our follow-up imaging and show and prove to them that what they had been doing all summer was working. And so now, instead of this progressing further into permanent joint damage, this was a horse that we were able to remodel its subchondral bone back and be able to go back onto its job successfully.
Yeah. That's very compelling imaging there.
This is a really good case example to highlight a few different things. One of using the PET as a screening tool, but also using it in conjunction with other imaging modalities. So this is a 15-year-old warm blood mare used for 5-star eventing that presented for an acute 3 out of 5 degree lameness that blocked to a palmar digital nerve block and had CT imaging initially that demonstrated some changes to the navicular apparatus in addition to the proximal phalanx, which on CT, on a first evaluation, we would not have considered this to be a very exciting structural abnormality. But it was interesting that on the PET, we were able to see a very, very significant amount of increased metabolic activity in this area, even though on CT imaging alone, this may not have been the most appealing or exciting lesion. Whereas everything that we had seen down in the actual foot didn't have any increased metabolic activity. And so we were able to follow this up both with CT and with PET imaging and show on the left, this is a 3-dimensional reconstruction of the fetlock as it's moving around. And you can see just how what we say hot that lesion is and how much increased uptake there is. And even just after 90 days of work modification, this was able to come back down, and clinically the horse was improving in conjunction with that.
Mhm. And the interesting thing about that one too, if you go to his CT, his follow-up CT looks worse. So if you
Mm-hmm.
had only CT'd the
Oh,
horse,
yeah.
you might say, "Oh, this is we're going the wrong direction here. Like
Yeah.
this is not
Yeah.
what we're looking for." But and the PET actually fit better with the horse's degree of lameness. So the horse had improved. The rider felt the horse was much more comfortable. And so we continue to serially monitor the horse, but the PET correlates a little bit better with the lameness than the structural change.
There was another good example. Dr. Bills was talking about this earlier in terms, back to our discussion on increased sensitivity. One area that this modality has been useful is for identifying changes within the foot and with structures within the foot that are very difficult for us to image, even with high field MRI. So the chondrosesmoidean ligament, which is one of our ligaments that goes between the navicular bone and the ungular cartilage, right, or collateral cartilages. This is an area that, unless it had extreme pathology, is really difficult to see even on an unweighted high field MRI. And with the advent of PET imaging, it was noticed both on FDG, so the soft tissue, or the NAF, the bone tracer, that you could appreciate increased uptake either in the ligament itself or in the enthesis on its attachments on either side. And so in horses where we have a blocking pattern that seems to fit with the foot or the distal limb and doesn't have any other significant lesions, it's been really interesting to see that this is something that we've been able to identify, again, owing back to the sensitivity of the imaging modality, and then being able to make shoeing and rest modifications with it, and then tracking it, right? And watching as the horse's clinical status improves, seeing that the activity in this settles back down as well.
And Dr. Crandall, what was that structure again?
That's called the chondrosesmoidean ligament.
One more thing I have to learn. Thank you.
Yep,
I
this one
think
can
we,
get lumped
I
in
think
with
we all
navicular
had to
disease.
relearn it.
Yeah,
Yeah.
uh,
It was an anatomy lesson, I think, for everybody
it
when we saw
was.
this again.
Yeah,
It
yeah.
was.
I think the most exciting cases that we've seen from this are the unexpected, right? I mean, it's always great to be able to see, this is a good case example of a horse that had a pretty significant bursitis associated with a chronic lesion that it had in its deep digital flexor tendon, and able to see on the FDG just how much activity there is, more so in the bursa itself than you can actually even see where the lesion it is here. And we knew this had been an old lesion and we'd been tracking it for a while. And so it was more interesting to see that this horse had more activity and inflammation within the bursa itself necessarily, as opposed to just the tendon itself being the main source of activity. But we've been able to identify cases that have active arthritis and synovitis based on increased uptake in these regions, when we're not finding any other traditional things that are pointing to a cause for lameness. We've had some good significant cases associated with suspensory branches. The proximal suspensory apparatus is very relevant, but there's also many times that we're ultrasounding suspensory branches and tracking these cases, and for months they may look exactly the same or even look worse. And it's nice to be able to attribute some metabolic activity to that, to then help determine should this horse actually be ramping up its work. This was a case where the horse was continuing to be lame and it had, a mild structural change in the suspensory branch. And we were able to help show and, help prove that, this branch was continuing to be an issue and we needed to make some additional therapeutic modifications to be able to address it.
Hmm.
The other good application, we were talking about using some novel radioisotopes for laminitis. We do currently use it for cases as well, especially cases that may be subclinical or may not have radiographic changes yet. We're able to identify, the left is an image looking at the FDG, which is very similar to like a 3D venogram, and being able to see where blood flow is through the foot. But something else that is often not discussed commonly with laminitis cases is the actual activity within the bone itself and pain arising from that. And so some of these laminitis cases can have significant uptake within the bone. And even outside of laminitis, horses can certainly have changes in the lamina. So this is a great case example highlighting that of a horse that had a pretty significant hoof wall conformation, that they had been struggling with correcting. And right where he has this outward flare and deviation, he had a significant increase in uptake in the lamina itself. And this horse had no other attributable causes for lameness. And we were able to use this to help confirm we need to be more aggressive with our therapeutic farriery. And as that hoof wall conformation improved, the horse clinically became sounder.
Hmm. Fascinating.
We can
Anything
go through
else?
we can go through examples all day. It's been great.
Yeah.
Um,
I want
you
to
know,
agree with you, Alicia, about the chronic laminitis bone pain. I think
yeah.
we have found something very similar where the degree of metabolic activity of the lamina on the soft tissue tracer, so the lamina itself, doesn't seem to be the driver of pain in chronic laminitis horses. It seems to be the remodeling of the distal phalanx. And so people are starting to explore some different therapies for that. So things actually like bisphosphonates to
Mhm.
decrease osteoclastic activity and things like that. But that is something we absolutely underestimated
Yeah,
before we started doing this.
yeah,
Yeah, it's been fascinating to follow up on some of those cases as well too, especially if you have milder cases of laminitis, right? I think
Mhm.
we all still question and take it personally upon ourselves, right? Nobody wants to put a horse back to work too soon. And so
Yeah,
it's been good to have something to provide some more concrete follow-up with, especially if radiographically we aren't seeing any changes, or a horse that maybe didn't have much rotation to begin with, to be able
yeah.
to provide some sort of information about what's going on inside that foot and give everybody more confidence into trusting how the horse is doing clinically and being able to push them forward.
yeah, yeah.
This is an interesting case. This is actually, this isn't just a modality for warm bloods and, high level sport horses and race horses. This case here is actually from a pony. That's just typically used for a walk trot canter, but it's a very naughty pony, and is reportedly was extremely difficult to block, if not impossible to block, and didn't have any distal limb effusion or soft tissue sensitivity. And so we had performed this as, again, a screening modality to try to see if there was anything that we could then follow up with what we were at the time considering to need more advanced imaging. And this horse had or pony had a very impressive amount of increased uptake in the distal straight sesamoidean ligament, which then when we went with ultrasound, we realized it is a very obvious lesion. And it's just fascinating because, again, with bone scan, right, and even inherently in the name bone, we for a long time thought that functional imaging was only going to be really useful in the bony structures themselves, but it's been really good to see the utility of this in soft tissue structures, and being able to use that alongside our other everyday imaging. And again, this is an example of a horse that didn't end up needing anything more advanced. We were able to find this
Yep.
and use this to say then with our ultrasound, which obviously this is an obvious ultrasonographic abnormality, but it was an area that wasn't even going to be looked at until we knew it was a problem.
The path to workup is not it's not one dictated by either party. We do it really collaboratively, and we want the collaboration with, the referring veterinarians. We really value all of the great like workup that you guys have done already, um, in order to point us in the right direction, and then we can get you the right information to, take over and treat the animals. This is probably an issue for another time, but it turns out that blocking has an effect on the FDG uptake sometimes. So if you have questions about, if you have a case that you think you're interested in sending, definitely just ping us and we can chat, and we might ask some targeted questions about when the horse was last blocked, because that might affect things in certain circumstances. But yeah, we just love to chat about cases if you think you have one that should be seen.
I think that's our favorite conversation, and we have
Yeah.
it probably every day of like which modality do we start with and which order
Right.
do we go, and how
Yeah,
is it going to work best for the owner? What can best serve the owner and best serve the horse,
Mhm.
truthfully.
Mhm.
yeah. And my advice for horse owners out there who are interested in pursuing this, just get in touch with your routine, your regular veterinarian, and they'll be able to
Mhm.
connect you with anybody who either can provide this imaging, or, as Dr. Bills does, interpret this imaging. Excellent. Well, this has been very fascinating. I can't thank you guys enough. like
Much
to
for
come.
organizing.
Yeah,
Oh,
Yeah,
for
thank you for
sure.
having us.
For
yeah.
sure.